Nizar, to kind of build this out, we finally have data in the non-clear cell histologies. We have data that you've reported. We have the ASPEN trial that just was reported at ASCO last year. So turn our attention to choosing frontline therapy in the non-clear cell histologies, papillary, chromophobe, translocation tumors, undifferentiated, kind of a basket of lots of different diseases. But what did these trials help us decide about how to approach those patients?
Well, this is, I believe, this diverse group of non-clear cell histologies, as you alluded to, is the most challenging to treat. And I think some of the challenges are based on our understanding or insights into the biology. We know far more about the biology of clear cell, and you led the field many years ago studying clear cell, and so the role of VHL there. So I think biology is still, I think, the key to really our understanding and our discoveries and to find more effective therapies. So now, there have been some retrospective studies in looking at the role of the approved agents, the sunitinib and the everolimus and others in non-clear cell histology, suggested that these agents are active. And the approval actually of the VEGFR TKIs, of sorafenib, sunitinib, and others, actually in the US at least, did not limit to clear cell histology, although the studies were done mostly in clear cell histology, except for the temsirolimus global RCC trial, where 20% of the patients recruited on that trial had non-clear cell histology. So based on the retrospective data suggesting there is some activity with the VEGFR TKI, based on the temsirolimus data in the global ARCC trial in poor risk patients, I think it was really natural to lead to a prospective trial comparing sunitinib, which Sandy mentioned has been on the market now 10 years, with an mTOR class representative, everolimus. So that led to the conception of the two randomized trials, randomized phase 2 trials, the ESPN that we led at MD Anderson with the Harvard Consortium, and the ASPEN trial, which was led by the Duke. And both these trials showed similar findings, but there were some differences. What we hypothesized was everolimus for non-clear cell based on the temsirolimus global RCC trial would be perhaps more effective than sunitinib. We were disappointed with the activity of sunitinib in non-clear cell based on our own data in a single-arm phase 2 trial, which we published in European Urology in 2012, where the response rate was 5% with sunitinib in non-clear cell. And this was a 60-patient trial. And the median progression-free median PFS was disappointingly very, very short of 3 months. So we built that hypothesis that maybe the mTOR inhibitors would be better, but we were actually surprised and disappointed that everolimus actually was not superior. In fact, numerically led to a shorter PFS of 4 months versus 6 months with sunitinib in non-clear cell. Now, what the ASPEN trial showed, they included some poor risk patients. They showed that for poor risk patients, everolimus actually was better than sunitinib. In the ESPN trial, most of the patients were good risk and intermediate risk. So these two trials, what they have informed us was that the two agents have modest activity. The patients with non-clear cell RCCs should still be considered for enrollment on clinical trials, and that's my take on the non-clear cell field. We still need better agents, better therapies. The currently approved target therapies are not that effective. I'll say there is a caveat here about chromophobe. Chromophobe, as we all know, is a more indolent tumor than papillary type 2, for example. And that tumor can respond, in our experience, in the first trial we did, the single-arm phase 2 trial with sunitinib, as well as the SPN, patients with chromophobe did respond actually to sunitinib in our experience. But they do also respond to everolimus because frequently these chromophobe tumors have mutations in the TSC1, TSC2 complex, as well as the mTOR gene pathways complex. So chromophobe patients with chromophobe histology do respond to either agent, but again, overall, the effectiveness of the currently approved agents is not high as we see in clear cell. And so there is dire need, in my opinion, to look at these tumors now separately instead of a basket with all the histologies grouped in a basket, but understand the biology of each papillary, chromophobe, the translocation. And I think now there are efforts that have started, collaborative efforts across academic institutions, and finally we're getting industry also engaged to try to conduct trials in specific tumors such as papillary, for example, or translocation or renal medullary carcinoma. And so I think it behooves us, and I think this is my message to the oncologists in the community: when they see a patient with non-clear cell histology, please refer them to institutions where there are trials for these tumors, because these are rare tumors. Unless we collaborate and have trials and we all refer patients to those trials, we're not going to have a headway and make an impact to improve the lives of these patients.